I'm here at the Johnstown estate where the National Institute of Preventive Cardiology of Ireland have just run a fantastic conference, and we had some very interesting debates on saturated fat and low carb and all those kinds of things, as well as the usual stuff. But I'm delighted to have brought Dr. Scott Murray to my rooms here to discuss particularly the latest 2018 ACC guidelines on treatment, which have given a coveted 2A evidence level rating for the use of CAC in middle risk patients. So great to have you here, Scott.
Thanks very much, Ivor.
And I hope the suite is to your liking.
Yes, pretty lush. Wouldn't have expected anything less.
Befits an emperor, perhaps.
Yes.
Yeah.
The drapes especially.
Oh yeah, the drapes are great. I love the drapes. So anyway, we get straight into it. So 2018 guidelines just came out. There was a lot of talk around the power of zero, as in a zero score in a calcium scan indicating medications perhaps not needed, but also the 2A evidence level has been reassigned to calcification scanning. So maybe just your thoughts on that general area.
Well, definitely something that needed to be done. We've been sort of ploughing around for some time discussing calcium scans and no one actually doing it when they should be doing it. My thoughts on it are clear that if you're middle risk, intermediate risk, whatever you want to call it, and you've got a family history and someone's thinking about putting you on a statin, then you should be in a scanner. There's no doubt about it. Because if you're high risk enough to be thinking about those conversations, then you're high risk enough to be knowing what's actually happening inside. So that's my take on it. When I get referred patients about, well, should they go on a statin or not, often it's because they've had a Q-risk 2, Q-risk 3 Framingham score, JBS3 done, and the GP's worried, or they've gone through an NHS health check, which was discussed at the meeting, and they've come out with abnormal cholesterol values and high blood pressure, for instance. And I think that these people, especially when they've got a family history, should be going through the scanner to know what their exact risk is, because until you do that scan and you put it into a different calculator, as we've discussed, a MESA or an AstroCharm, then you don't know what the exact risk is until you net reclassify that patient.
Yeah, absolutely. And the focus in the guidelines was this year more so on looking at people who are lower risk when they really find out their level of disease from the scan, rather than focusing on finding the really high risk in the middle risk area. But I think for me and IHDA, who I work for, probably for us there's even more focus on finding the genuine high risk with high disease in the middle risk category. That's really focused on saving the people who otherwise might be missed.
Yeah, sure. And I've been hit with colleagues with some criticism that, this is going to increase some patients' concerns. But a lot of patients actually need that because there's a sort of human sunk cost fallacy. You won't change your behaviour or really listen in some cases to what we're saying until you have that plonked in front of you. You have disease in the arteries, and suddenly your risk of heart attack has just escalated significantly. And similarly, there are people who are incredibly anxious who get a CAC score of 0. And then you can say, this is really good news. This is really powerful. Your risk of a hard event is less than 1% per year. And your chances of actually having obstructive heart disease is really low. I think in the PROMISE study, which was a study done by Pamela Douglas and colleagues, a large randomized study looking at people with sort of indeterminate chest pain with an intermediate risk. If you had a CAC score of 0, your chance of having actually a 70% stenosis was something like 1%, 1.4%. So even though it doesn't tell you all the degrees of plaque or the degree of stenosis you could have, it gives you a really good example for no contrast, no risk to your kidneys, low radiation, that the chances of you having something serious are pretty low.
Right, and that is, there's a hashtag power of zero or the power of zero out there at the moment, and it looks like that campaign for many years has been successful in the recent guidelines.
Of course.
Yeah, and that is actually great you bring it up, because constantly I'm seeing this argument about the CAC of 0 is not a guarantee, which it's not, you can still in the following 10 years have an electrical problem that could
Yeah.
cause a heart attack, not atherosclerotic. You could have rapidly advancing diabetes, so you get a 0, but in 3 or 4 years you might not get a 0.
Yeah.
And you know, you may have a soft plaque that ruptures, but I think the stats are key. Like you say, if you're 2% chance in the next 10 years with a 0 versus 37% in the
Yeah.
big College of Cardiology study, 37% with a high score, it gives you a huge amount of information.
Sure. I mean, we can run through. I've written down some actual things just so we get the point across here. So, in this PROMISE study, there were 1,457 patients had a 0 scan, and 21 of those were determined to have had some form of event. Now, 9 were hard events, which were undeniable. So that was 0.6% of the cohort had a hard event with a CAC of 0. But when you delve into the data, the 21 patients who had some form of event, 2 of those were determined to have had a severely abnormal CTCA, i.e. a stenosis of greater than 70%. So that's 2 out of 21 patients. 2 had a moderate stenosis, 50 to 70. 6 had a mild, so less than 50%. And 11 of the 21 had a completely normal CTCA.
Wow.
So the reason for their event was either something embolic, a minor plaque erosion of some plaque that wasn't visible on CTCA, spasm, a type 2 myocardial infarction where it's demand and supply. So there are other reasons for having had myocardial events that are not down to plaque. It's really important that we ram this home, because even if you do have a non-calcified high-risk plaque in inverted commas, so soft plaque, there was data from the Israel trial that was shared by Paul Shonagin, I think, that showed that even if you've got that plaque over 9 years follow-up in a diabetic cohort, the chance of that giving you a hard ACS is 3.4%. So 96.5% of those plaques in follow-up do not cause acute coronary syndromes. And in actual fact, if you've got a calcified plaque further downstream or a calcium score over 100, then you're looking at potentially a 22% risk of mortality in 12 years. So you balance those things up, I think it really, again, speaks to this power of 0.
Wow. Now, again, I'm familiar with a lot of studies, but those recent ones maybe not fully. So just to parse that out, we've got a low calcium score with known soft plaque in diabetics, high-risk population, only 3.5% of events in the 9 years.
Yeah.
Never mind mortality, probably trivial amount of mortality, versus the high scores, 22% mortality in the 9 years.
So that's in the Cardia trial.
Right,
and that's I think it's 12.5, so it's a different trial. But Kuram Nazir, if I've got his name right, he's beat me to a few things. In fact, I said to him on Twitter, "Dang, you beat me to this." He's looked at calcium scores in FH patients, and he really is a leader in this field, along with Blumenthal and Budoff and all these guys who've done such great work to try and get this point across to general cardiologists. Why are we not using this? What are we losing out on? And it's not money, because it's cheap. It's not radiation, because you can do it with low radiation. It's just inertia. That's all I can, spell it out to be. And the amount of money that we're pumping in cardiology to pulling people out of the river when they're having their STEMI or, finding out they're just dead at home. The amount of money that's spent on atrial fibrillation ablation that's permanent AF, you're looking at £7,500 for a procedure that has a 50% success rate. So you start weighing up these things, and this is why in the UK I've been so vocal about saying put the money into the simple things. Yes, find out if they're hypertensive, insulin resistant, their cholesterol's abnormal because of those issues, but then do the right thing for them off the bat. Don't just leave them on a statin and say, "Oh, off you pop."
Yeah, exactly. And the power of 0, when you think about that statin decision, and the statins do have an ameliorating effect, so they reduce incidence of events, maybe not so much hard mortality, but they have an effect. But in recent studies by Joshua was the lead author, I can't remember his second name, it was an associational study, but very well adjusted insofar as you can, and he showed that 0 or less than 100 calcification score, the 10-year event rate with statin was pretty much no different than non-statin.
Yeah.
But then for the greater than 100 calcification, particularly greater than 400, the statin showed apparently an associational very large benefit.
Yeah, yeah.
So there's much more people in the lower calcium score group, so there's a huge amount of medication that could be avoided for people who would like to have that choice.
Yeah, I mean, I think even when you scan high risk groups such as, like, psoriasis, HIV, rheumatoid arthritis, you're looking at potentially 60% of patients getting a 0 score, and then you start thinking, well, you may have avoided 10% getting diabetes because of a blanket statin. The combination of diabetes plus an inflammatory disorder such as psoriasis or rheumatoid or HIV, the combination of these two things is going to be equally detrimental. So if you can get a 0 score, you can start to think, right, what's the next best thing to do in terms of how do you maximise your lifestyle so you can keep it 0? Because it can change. It's a dynamic process. So I think that's really important message to send out to people, that if they are concerned about their cardiac risk, then by all means do your heart age tool, know your numbers, go and get checked. But if you've got this strong family history, your dad, your brother, your sister, whatever's had a stent, a bypass, dropped down dead, been told it's a heart attack, go and get checked and demand to go and know what is going on inside.
Yeah. And for sure, Scott, and legally, of course, any general practitioner can write the letter to get the scan. As you say, the radiation now is down to even as low as 0.4 millisieverts, like a mammogram.
Yeah.
Or at worst case, probably 0.7 or 0.8.
Yeah.
Interestingly, I put that in the Radiological Institute risk calculator, and for a 50-year-old man who has a 49% chance, lifetime chance of cancer, 49.00. If you put in 1 millisievert from a CAC scan, he goes to a stunning 49.005% chance. And even that is theoretical. So the radiation is almost offensive as an argument, even though population exposure to radiation should tend to be minimized. For something as valuable as a scan, I mean, it's a joke to bring it up, really.
Yeah, so I get really upset in my institution because there are people who are being nudged towards myocardial perfusion scanning, so maybe nuclear scanning. Now, you've got 10 times the risk if you go through one of those because of the amount of radiation you're exposed to from the tracer. So, it's weighing up the power of what you're doing. Yes, if you want to prove there's ischemia there, or the heart's not getting enough blood, then there are other tests. There's stress echo, there's stress MRI, which carry no radiation. So I think the radiation thing is overused, really, to sort of knock the discussion away from this. And with scanners improving so much, I mean, various vendors have got various new protocols with their scanners to keep the KV down, keep the radiation exposure as minimal as possible, flash and turbo flash calciums, these sort of things, so that it's always evolving. So fingers crossed for the future that we can do it cheaply and safely.
Yep, better, faster, cheaper, as we used to say in industry.
But still good.
But still
fast,
super
cheap, and
good.
Yeah.
It probably still is for a fast, cheap scan, it's the best measure of atherosclerotic burden still, 40 years after its invention.
Yeah, sure.
For utility.
I mean, there are people maybe in the interventional world that say, okay, you get a CAC of 0, very good, but you could still have plaque in there, you could still have disease. So are we saying that people with a CAC of 0 have no disease? No, we're not saying that. But what we're saying is that if we put a IVUS catheter or an OCT catheter inside your coronary artery and did a pullback, we may see intimal thickening or the start of plaque developing, but it depends how far you're going to push it for the detection of plaque. And then when you've got that plaque, when is the right time? Say you had plaque on IVUS but no, or OCT, and no plaque on a CT, CA, the risk of actually going through the procedure of putting the catheter down the artery and pulling it back, the risk of doing all that invasively is higher than the risk of just getting a calcium score and accepting what you've got. You know, in some studies, there's a 1% risk of causing an event by putting an IVUS catheter down. So you've got to weigh it up, and you've got to turn off at some point and say, well, this is enough. This is your risk. You accept that or you don't accept it, and you accept to take pills or not take pills, depending on what the stats are. And you know, it's your choice, it's patient choice. And the 2018 guidelines state that. They say it's about patient choice at the end of the day, with all the information, shared decision making.
Shared, which is a fantastic phrase. I mean, it's the doctor's expertise, the best data.
Yeah.
If you don't measure it, it don't get fixed. But with the calcium scan, you get amazing data, and then the patient's risk tolerance and, you know, what they want for themselves.
Yeah.
You know, absolutely. One last clarification, actually, because I know we're tight on time this morning, and you already went through it, to be fair, but many times I get asked the question, well, you know, I asked for calcification, but I was told to get a CTA, a CT angiogram,
yeah,
because it gives more data. But I always answer, look, the CT scan, the CAZ score is the quick with hugely valuable information. And the CTA I perceive more as if you're symptomatic or you see some problems in the calcium scan, maybe for deeper diagnostics, not for screening.
Well, no, I mean, I think that NICE guidelines in the UK state that if you do have even a calcium score of 1, then you should consider progressing on to do contrast injection. And there is a move in the most recent guidelines to say in young patients under the age of 45, because MESA was over the age of 45, you can give general risk predictions for the over 45 group, but the under 45 group, you may be missing soft plaque. Now, I think, yes, that is possible. We have seen people come through and they've got non-calcified plaque in important positions at a young age. But if you take the totality of the evidence so far, like I said to you, 1.4% of people with chest pain with intermediate risk when they had a CAC of 0 had greater than 70% stenosis, soft stenosis, on a full-blown CTCA. And what normally happens is, in my practice, if they've got calcium, they do go through and have, and this is NHS, a full-blown contrast evaluation, so that we can actually determine these small numbers. And it is quite often different from my colleagues in that if someone's been referred and they've got atypical chest pain or deemed to be non-cardiac, but this is being used as their initial screening test for chest pain, you often talk to the patients and it's gone away, or they had a stressful period, or you rub their chest and they go, ow, and they've got, you know, non-cardiac chest pain. And if they get a 0 and they're 50 or 60, I take them off the table. I don't go through with the contrast injection because of this known data that your risk of an event is 0.6% or less than 1% per year, and your chances of having a 70% stenosis is 1.4%. So if the patient is happy with that, then you can go away. What it doesn't address is, should patients with no calcium but non-calcified plaque have aspirin and statin? That's the thing that it doesn't address. Now, if I see a patient who subsequently goes through a scan and has non-calcified plaque but significant, then they tend to go on for functional testing or more invasive testing to see whether that is causing a functional stenosis if it's greater than 70%. So those patients are going to go on and have more tests, in essence, potentially more invasive, especially if they've got a really high risk of family risk of events. Because you can't just say, your risk's, you know, less than 1%, don't worry. You know, because human nature, you know, we evolved to worry. That's how we got out the savannah. The only ones who survived were the ones who worried. The other ones got butchered by lions.
Yeah, sure, fell off cliffs trying to achieve unrealistic goals.
Yeah, so you have to, you know, you have to make sure the patient goes away with a clear clear enough for whoever it is, their own, sense of how they perceive their risk. If they're happy, then that's probably the right thing to do.
Yeah, absolutely. And because the implications are so serious, of course, even small risks have to be taken seriously by some, and then but others will be quite happy to have an extremely low statistical risk and will not want meds. Maybe a last thing we'll close on, really the last thing is the other point that if you get a low score, but you have particularly high risk blood markers, in fairness, we always say to people, if you're a high risk in Framingham or high risk in Q risk, you've already kind of got your answer. Even if you get a 0, there's something wrong.
Yeah.
So in fairness, blood risk markers, if you have multiple bad ones or family history and they triangulate together and it's a bad picture, you got to assume there may be more risk than a 0 score today indicates, and people should be looking after that.
Yeah, sure. I mean, you can net reclassify someone in the MESA or AstraCharm formula so that you get their cardiovascular coronary risk in the next 10 years, and that may be below a certain threshold. But if they're obese, hypertensive, diabetic, they've got other risks. We're focusing on the coronaries: stroke, aortic dilatation, left ventricular hypertrophy, there's kidney disease. You start stepping back and looking at the full picture. We tend to want to focus down on specific things, but that patient's still at risk, and that has to be dealt with by the right lifestyle and taking forward what's the right treatment if you can't get the numbers down into good levels. Because, like we say, we talk about lifestyle a lot, but some people can't do that. They can't embrace it. They admit that it's just not possible for them. I've got colleagues who are doctors who've high scores, and one guy in particular said, "Yeah, I know, but I just love Greggs."
You just love Greggs?
He just loves Greggs. He can't give up going into Greggs, the pie shop. So
I wasn't sure what Greggs.
Well, you're not sure.
Oh,
sorry. For everyone, Greggs in the UK is a well-known bakery. So I'm looking at him saying, you're Asian, got a low personal fat threshold, starting to, look dodgy, numbers are going off, you're going to have to do something. He said, yeah, but Greggs. So, but
so
then
many
you start
carbaholics.
saying, if you can't do it, it's difficult. People have binge eating disorders, there's all sorts of things going on. When you drill down into why that's happening, it can be things that have happened in previous, parts of their life. You can't judge. You have to just say, well, you can only do what you can, and if you can't do it, we may need to use medication, because there is a gap there, a potential treatment gap. So I think it's about balancing it all up and what's right for the person.
Yeah, and guys like that, in fairness, a calcification scan with a high score can give them the wake-up call to, even if they can't stay out of Greggs, they can at least get the appropriate medications to mitigate their risk and maybe try and go to Greggs a little less often. Hey, listen, thanks a lot, Scott.
Thanks,
Great
Ivor.
stuff.
Thanks for having me. Okay.
This is Scott Murray, current president of British Association of Cardiovascular Prevention and Rehabilitation, BACPR, at the NIPC conference in Johnstown House Hotel. Thank you.
Thanks.